Lindsay will return to us.
I didn't do it, I promise.
That's fine. Lindsay will return to us in the spring. So normally we're a 3-person team. So today is all about ITT, interdisciplinary training. So ITT is where we break into 2 teams. Each team has an identified patient each semester, where we do all of our evaluations. You do your evaluation that you would do in your discipline like normal. Family does an evaluation. Everyone does an evaluation, except for there's a couple of people and you have a little asterisk, ABA, advocacy, community engagement. You don't have evaluations per se, but you still have a role in the interdisciplinary training. You do normal documentation. These visits are scheduled in Epic, just the way all of your other visits are scheduled. They're on the supervisor's schedule, not your personal schedule if you do have a schedule. The big thing is there's no bills that should be dropped. They are free. Your supervisor should be able to work with you on how to drop a no bill. I promise someone will get billed for something. And it's not your fault. But if at any point a family tells you, if at any point one of these families says, I got a bill, that means you should send the family back to me so that I can work to, Randy already emailed the family who's coming in next week. If you get a bill, do not pay it and let us know right away. So for team, we'll work on getting any bills that are dropped cleaned up, but we try really hard not to drop those. Just our system really likes to send bills. So the ITT cases, these kids are kids who are already referred to DDBP. So they had to have a referral into DDBP. Basically, there's this, I was explaining this to Brandy and Maddie this morning. There's just this couple week time frame where I reach out to our intake person in DDBP and I say, send me your new referrals that you've gotten in the past week for these categories. So this semester we're doing school age kid. Next semester it'll be a young child with a rule of autism. And then Colleen just sends me a bunch of patient names and numbers. And then Lindsay and I go through them and identify, if you live 2 hours away, you're probably not a great candidate. So we work on identifying who would be a good candidate for a learning experience. And then we just start cold calling people and saying, hey, do you want to do this program with us? So these children were referred usually by their primary care doctors, but it could have been a different source. It could be another subspecialty at the hospital refers, or a school psychologist refers. But most referrals are primary care. And then the types of referrals we get in DDBP, rule out autism, rule out developmental disability. There's already an established autism diagnosis and we're transferring care, learning concerns, ADHD, and then we have specialty clinics, spina bifida, Down syndrome, RTS, a couple of other genetic disorders, where there's a specialty clinic for that specific condition. The average number of referrals into DDBP in a month is about 600 referrals. So not everyone gets in. And there's an intake triage process to determine who can be scheduled and who meets our criteria. So with a general referral that comes in, so the same way these kiddos came in, the referral comes in, there's a CSR, customer service rep, in DDBP who triages it initially. She's looking for certain categories. If a child clearly meets these categories, these age groups, this diagnostic question, this where they live question, she just sends it on to the scheduling team. They get scheduled into somebody's schedule. If there's any questions, it goes to a higher level of triage involving medical team members, to medical or treatment team members, depending on the referral question. Who should see the child first? Is the child appropriate for us? And those decisions are then made. And then if it's not a match, so the child can't come for some reason, the referring person is told that. So primary care gets that communicated back to them. The school psych gets that communicated back. So we schedule a visit. If the child is in school, our schedulers say, if your child has an IEP, please bring it to the appointment with you. Families forget, it's hard, don't worry about it, we see them without it, it's fine. Sometimes if social work isn't on beforehand, we say, you can go ahead and email it to me and I'll get it scanned into the chart before you visit. So, this page is just some of our specialty clinics. So we have DADIT, which is for toddlers and infants. We have arena style evaluation days, which is a multidisciplinary team doing evaluations at the same time with a predetermined come back for your results visit. Autism, specialty clinics, depending on age. Down syndrome, Thomas Center, they're going to come talk to you in a few weeks, 2 months, about their clinic. There's an RTS, there's spina bifida clinic where I work, we're coming to talk to you. There's a RET clinic that is housed in neurology. Then I also work transition and adult clinic, that's where my people from. So those are just some of our specialty clinics, but clinic runs every day, all day long, just different people are seeing patients on the third day. So depending on age and reason for referral, a child might come in a couple of different ways. A child might see an MD first, a child might see psychology and speech first. A child might come see the MD and they get referred on for those other evaluations. So it doesn't, the coming into our system doesn't look the same for everybody. It depends on age and reason for referral and insurance. Additional visits will be scheduled after your first visit, almost always, no matter what. It says May, but we usually do more visits. And then once all the evaluations are complete, that's when we do the information sharing session, which is typically either led by psychology or the MD. So come back, go over all the evaluations, diagnostic findings, and treatment recommendations. Next steps, what are we going to do? Get your referrals in and start getting services. So these slides are really hard to read, but not there now. So this just kind of works for the interdisciplinary assessment. Identifying. Oh, was that? I didn't realize it was up there. I'm still going to keep looking here for now. Referral family. Like, what was our referring question from a provider? But then what is when the family arrives? What's your question? What's your concern? Why are you here? Sometimes it answers, they told me to. And I don't really know, I don't really understand. Versus some families come in very much. I have another child with autism, I'm really worried that this child has autism. Providers review previous assessments, gather information, determine which assessments are needed, and complete assessments either together or separately, depending on, is this an arena visit, is this an MD, then psychology visit, progress. I can see it. Awesome. And that worked even. Wait, did I go? Where did that go?
Yeah, you're on it.
Oh, okay. Well, now I can get that because that's going to confuse me. So then there were some readings for today. And one of those readings was about how the assessment process is actually an intervention. So for these kids who are coming, they're going to see you guys like every week. They're going to see at least one of you week after week after week, like 4 or more weeks. And you ask a lot of the same questions, which we're going to talk about later. We understand why. And from our different disciplines, we might ask the same question with a different lens. So for the family, we ask the same question, but we might have different thoughts when we're asking this question. But as they have time to reflect on the questions we're asking over and over and their responses, they might start seeing a pattern. And we sometimes see parents and families have some changes in what they're doing or what they're thinking or how they're answering some of these questions as the evaluation process goes on, because usually they're getting some feedback from us. So, you know, if a child's having a really hard time struggling in that first appointment, usually we're making some changes about what we're going to do at the next appointment. Okay, so he really struggled, but he really enjoyed bubbles. So guess what? The next person seeing him is going to have bubbles ready to help us through the appointment. And so we might see that the parent starts telling us, well, homie really likes this, so we've been using this more to help us get ready for this. So That's just how the intervention process, the assessment process is an intervention in and of itself. And we might see changes in the family as we go through our evaluations. Maybe totally normal. Okay. Yes. So each clinical discipline meets with the family and the patient, usually. Each discipline will be responsible for presenting your evaluation and your process, what happened during your appointment, to your ITT team. Each team determines how information will be shared back to the family at the information sharing session, which is already in Dr. Pam's schedule with Suma and Maria. And really important, do not put names on campus. It's not the right encryption. So for patient privacy rights, we cannot put names on Canvas. So just use initials. When you're doing your ITT presentation, just use initials. Okay. So every other week, your team will meet to talk about your patient who saw your patient since the last meeting and present out your information and your findings. Then we're going to have one team meeting right before that information sharing session where we go back through highlights of everyone's findings, top priorities for next steps and treatment recommendations, and did we answer all of the parents' questions, which will be a question we keep probing you guys at each meeting. Identifying what are the services, what are the resources, what are the strengths of this family, this child, how do we deliver the information, who delivers the information. We have a whole meeting pretty much dedicated to having that conversation as a team. So that's called the ITT case conference. So there's a whole, one of the meetings on the schedule, you'll see it says case conference. It's titled that way. So that's what that meeting we do. I can try again. I just said this. So we have the meetings. This probably should have gone before that last slide. Time is limited. Your time will be assigned on your agenda. Your minutes, your agenda planning person will let them know how many minutes you think you're going to need. Psychology friends often ask for a long time to talk about all the evaluations, all the measures, what happened, all your stuff. Kind of takes a long time to talk about. Try to give you days where there aren't very many presenters. So it's okay if you say, we say it averages 15 to 20 minutes per person. Your day, you might say, I want an hour. Social work friends might say, I got it in like 5 to 10. And that's okay. So if you know you're going to need a long time based off of your testing and your evaluations, or like sometimes people want to do some education, like audiology sometimes says, like, this kid's hearing was normal, but this is all the things we did, and it's really kind of interesting to listen and see all the things that were done. So you might say, I won't need 30 minutes instead of 20 minutes. That's cool. We'll work with you, but the person who plans your agenda helps them to know ahead of time if you think you're going to need a lot of time or not very much time. Okay. So this is what we're looking for in your presentation. We don't care what format you put it in or open. If you're creative and you want to do some system we're not familiar with, that's totally fine. But we want there to be a presentation so that we can all follow along. We want to know what tools, what measurements do you use, what your evaluation results were, which you can put, you can see in here, like what exactly we're looking for, what questions to answer. This presentation goes on Canvas for everyone to be able to look back. So if somebody misses an ITT meeting, they want to look back and see what was done at the meeting. It also helps with our ITT case conference meeting. There's evaluation results, scores, measures. Most people like to put those in table format so we can read them. Much appreciate it. So make sure we can read what they say. Okay, I keep forgetting. No. I'm done.
Hello, I'm Sally LaCroix, and I want to talk to you a little bit more about what a standardized test is. Can you all see that okay? And I apologize for all the glitches. The issue was that if we logged out to get into my account to pull things up, then we would have kicked everybody off of, kick our friend off of Zoom, who is identifying as a Steelers fan, I see. And I'm wondering how many of you are upset by that after Sunday's game. Anyhow, so she's all right with it. She's all right with it. Okay, so we're going to talk about what a standardized test is. A standardized test is administered and scored in a consistent manner. Most of the time they are published. There are books that come with it to describe how you perform the test. It has a specific purpose. When you look in the book, you can see the specific population and age groups. And oftentimes the standardized test has been normed on a number of children, hopefully a bigger group regionally. And now we're starting to see where, there's cultural differences in the way that babies are raised and kids are raised and opportunities they have to play and whatnot. And so sometimes they are now taking tests like the Peabody, which is a gross motor and fine motor test, and validating it on children in India or whatnot. And so looking at what the norms are regionally and also between different cultures and countries is important. So there's several purposes of standardized testing. The first one is screening and diagnosis. The second one is to gather information and determine a baseline. The third is to determine eligibility for services. So a lot of norm reference tests are used by groups such as EI and the school systems to determine if a child scores low enough to qualify for services. So there's usually a standard deviation or a Z-score or a standard score that we're going to talk about in a minute that they utilize to determine what the cutoff is. And then the last thing is to plan intervention in that big group of like norm reference test. A norm reference test is a test that has been normed on a population of children. So there's a bell-shaped curve that has been identified on those skills, whether it's speech skills or language, motor skills. And you can look at their performance at a moment in time. An outcome measure, a criterion reference test, is something that you can test at one time and then test again, and it'll give you information about the change over time. But it wouldn't be appropriate with a norm reference test to test them one time and then test them again and look at those scores and necessarily make an inference about how much change there's been. You can say there's been an improvement, but that test wasn't designed for that. It will help you with discharge planning and outcome measures. Those are a little bit more true of the criterion reference test. In terms of planning intervention, sometimes you can go back to the standardized test and see the areas where the child scored lower and then identify that as a goal for therapy, right? So it does give you some really good ideas about what a child should be doing at that age, or maybe even a step before that. Another thing to think about is that a standardized test is only one piece of that overall puzzle. And you all are going to learn that the test that the physical therapist does is only one piece of the entire puzzle of the multidisciplinary team and impressions of this child. But a lot of times when we think about the ICF model, the International Classification of Functioning, Disability, and Health, those standardized tests often only measure body function and structures and or activity. A lot of them are in that activity category. Some are devoted more to participation. That's become a newer thing, but it's something we ought to be thinking about. But remember, there's environmental factors and personal factors that affect this child's functioning, and we will talk about that a lot as well. So the standardized test by itself is only a piece of the puzzle. This is that norm reference curve. So hopefully nobody has flashbacks to statistics class when they were in high school. But basically, a norm reference test used normative values from a population to form a bell-shaped curve. And so the very middle, the very top of that curve is the mean. And there's a standard normal distribution. So each of these on the bottom are standard deviations above and below the mean. And what I also want to point out is that you might have a standard deviation of, let's say, 1.5 standard deviations below the mean. That also corresponds to the percentage and the percentile, sorry, and the age equivalent. So basically, when a child scores somewhere on this curve, you can draw a line directly down and you can get the age percentile and the age equivalence and the percentile. So the scores generated by the standard test include the raw scores and then these age equivalents, percentiles, and standard scores. So the raw scores are the scores that you add up in each section of the test or subsection and then those are converted to percentiles and standard scores. Most of these tests have books with them, and we have to do a lot of sort of looking through tables to find the number that corresponds to the whatever. You're shaking your head. Elizabeth, you've done this a bit. I'm dying for the day when all of these are computerized and I can plug in a number. And I think the bot will do that for us now, although we don't always know how to log into that system. But that would be lovely. But what you all need to know as a non-clinician, or even maybe a clinician that hasn't had to do this, these tests can cost thousands of dollars, just the test itself. And then some of them, the license states that you have to buy their score sheets. So it can be an ongoing cost. And there's ongoing costs related to development, and they're usually trying to stay on top of changes in development. And so there are new versions coming out and being revalidated. Some of the tests will also provide an age equivalent. An age equivalent is the age that 50% of children at that age can demonstrate the skill. Do you guys remember taking reading and math tests in school and getting the report home, and it had a bell-shaped curve on it, and it would say that Bobby scored in the 90th percentile, which means he scored better than 90% of his classmates or equal to, and he scored, he's a 10th grader, he's reading at a 12th grade level, right? It's easy for us in our mind's eye to think about what a 12th grader might be doing versus a 10th grader. Maybe we see it a lot in motor skills where, a child is maybe 3 years old, but the test says they're functioning at a 6-month level. And we know as PTs, that means they can sit well, but they can't do a lot else. They're not crawling, they're not pulling to stand. But there's an issue with that because only 50% of 6-month-old children can do the skill of sitting that this child has been tested at. Age equivalent is something that parents latch onto, and it's something that I really want to encourage clinicians to educate them a little further about what the standard score means and what the percentile means, because that's actually more important and a better indicator of how the child is functioning. So we talked about the age equivalent scores. And then, so for example, if the average score for 50% of 6-year-olds on a test is 40, then any child who scores 40 has an age equivalent score of 6 years for that skill or area. Percentiles and standard scores are normally distributed on that bell-shaped curve where age equivalents may not be. So as much as you might want to forget that statistics class, this is going to be really helpful for you moving forward, is understanding what percentiles are and standard scores are. So percentiles are when it demonstrates the number of children of the same age that scored lower than or equal to the child tested. So Angie scored in the 70th percentile. She scored better than or equal to 70% of her age-matched peers. And in some cases, it would be even more important to say her age-matched peers with the same diagnosis, right? Because some tests are even getting that more specific, diagnostic specific in terms of function. Obviously, if we hear a child that's performing less than or equal to or greater than or equal to 30% of his peers, that's a great difference in terms of being lower in their performance. The standard scores is any deviation from the mean in that bell-shaped curve. It may also be called a Z-score. there are other names for it at times, but typically a standard score is Z-score. So if the child scored 0.5 standard deviations in the positive, they are 0.5 standard deviations above the mean. And again, when you look at the bell-shaped curve, normal development is typically in this plus or minus 1 standard deviation away from the mean, is typically considered normal. A lot of school districts and folks looking at eligibility will use 1.5 to 2 as an indicator of needs for services, whether it's related services of PT, OT, or speech in the school system. So it's getting outside of that dark blue space. And you can see that like 68% of children score in that middle range. Okay. So when you start to talk about, 30th percentile, you're talking much lower on the bell-shaped curve. And this just shows you the standard normal deviation. In this example, the child scored in the 7th percentile. So he scored better than or equal to 7% of his age-matched peers. And he was 1.5 standard deviations below the mean. So just an example of how that all lines up on the curve. They're just different ways of talking about the same data. We would like you to avoid when you're doing a presentation on your results to avoid sharing the test language if it only says this means they're moderately impaired or they're not like others or they're more like others. And Sam, I don't know if you've done like the sensory processing measures, but that comes up frequently in like the sensory processing measure and the short sensory profile. But there is a norm reference curve and they will tell you what the Z-score is for moderately impaired. My moderately impaired might be different from someone else's moderately impaired. That's why those numbers are so important. Looking at what that means in terms of the normal distribution. And those Z-scores provide a better description. When we're looking at a standardized test, we need to make sure that it's both reliable and valid. Reliable means that it produces a consistent, repeatable result. Valid means it measures what it's supposed to measure. So when you look at this schematic, which one of those arrows on the target are reliable? So if we look at A, B, and C as being the targets across, from left to right, which ones are shown to be reliable? A and C. So they're consistently doing the same thing, right? However, and the one in the middle is not, right? It's all over the place. It's scattered. And you guys might find that some of the performance of the kids we see, they might do well on one test and not as well on another. And you have to use some inferences around, your professional judgment about why that might be. But in terms of a test, which one is valid and reliable? A. So it's measuring what it's supposed to measure and it's consistently doing so. So keep in mind the psychometric properties of the test, the purpose for which it was designed, the sample used for norms. There's a test out there called the Denver, which is a screening test for children for motor skills. It's still commonly used in pediatricians' offices, but it was normed on less than 1,000 children in a specific region of the US. The Ages and Stages questionnaire is something that's more routinely used. It's used in our division in OTPT, and it was norm referenced on 15,000 kids from multiple regions. That, in my opinion, makes the test more valid in terms of looking at a norm distribution to have a larger sample from many places. You need to know what the strengths and weaknesses are of the test. And that's something that we're going to learn from folks when you present is, I picked this test because of this reason, but because of the child's language skills, it made it hard to get a good measurement of their ability. So you are going to be able to share with us some of the nuances. Just because a test is valid and reliable does not mean it's useful in all situations. Other considerations are how much time did you have to do the test? What was the setting and the child's behavior? The ability of them to follow commands, the skill level of the person providing the test. If it's the first time you've ever done that test, I know the first time I did the Peabody, it wasn't as good as the 10th time I did it. And then the cost to administer. So the selection of the measure, we talked about a little bit already. The questions you're asking is what developmental functional needs need to be examined? Why was the child referred for testing? Do they have an existing diagnosis? Is the testing meant to help support or refute a diagnosis? And what is the caregiver referral source concerned about? It is very common for us to be in situations clinically where we feel that we have to modify a test because the child is not able to perform the item. Sometimes it's because we feel that they aren't able to follow the directions, right? But in the bot, and Michelle can correct me, I think you're only allowed to give the instructions twice, and it's verbal. And when you do more than that, you are not following the test performance criteria. And so things like changing the sequence, if that's a specific thing about that test that's necessary, excluding items, rewording, some of them are very exact, the wording you give, or providing demonstration when demonstration is not allowed, modifying the materials or equipment. Some of these tests come with very specific items that you have to use. And let's say nobody can find the pegboard for that test that day, going and grabbing another one from the closet that doesn't belong to that test may invalidate some of those results. If you allow extra time or additional tries, oh, you're getting close, let me see you do it one more time. And that's the 4th time they've tried it. So you can sort of learn the test too. And so we want to make sure to stay to the amount of trials that they are allowed by the test. Accepting parent report. Well, Johnny can do that at home. I've seen him walk reciprocally up the stairs at home. There's only one test I'm familiar with in OTPT where there has been some validation of using parent report, and it's for the gross motor function measure in children with Down syndrome, because sometimes behaviorally those kids won't participate. And they actually did a study. So before you accept parent report, most likely it's not allowed on the test. You have to see it in the clinic. And then estimating or assuming the scoring of an item not tested is a big issue. So all of those things mean test modifications mean that the test results cannot be trusted to the same degree. In a standardized test, those normed values that you're then going to use to plot their scores, those were gathered in a standardized way, right? And so the difficulty then is you can't compare them to other children, and problems with comparing them to the norms. You good? Ms. Martin, you want me to keep going?
I feel like this is a repeat.
I think you are right.
For sure. Can that? Something got out of order. Okay.
Yeah.
It's just out of order. So keep going.
Okay, sure. So the case conference worksheet is something that we will fill out throughout the semester. And it's done by the note taker. We changed this form in the last couple of years based on feedback. And so at the end of the semester, we'll love to have your feedback about what went well and what didn't. We used to have this broken up into sort of more discipline specific findings, but there's a lot of overlap, which is one of the really beautiful things I've learned in hanging out with in this multidisciplinary group is seeing the overlap between different disciplines. And so we've made this more by body system. And there might be some OT findings in the speech section or the behavior section, as well as some speech and psychology input into like the behavior section. ISS and IATT, if you haven't figured out, we like our abbreviations. It took me a while to learn these when I started with the group 4 years ago. So don't worry if it takes you a minute. Basically, ISS stands for Information Sharing Session. And that happens in the Division of Developmental and Behavioral Pediatrics when there's been a multidisciplinary test done at different times. And the pediatrician, advanced practice nurse, or the psychologist sits down with the family and shares the information that was gathered from those tests and what they mean in terms of diagnosis and recommendations. So the eval results are shared, the recommendations are explained and prioritized with the family. It's very common in PT for us to see an issue or 10 issues with their alignment and their strength, and to make a number of different priorities about what we want to see them do, but perhaps there's a mental health issue in the family that's a bigger concern, or perhaps they're actually more delayed in speech and that needs to be a priority. So we will talk together about what should be prioritized and really lean on our social work and family colleagues to guide us into why are they here? What were parents concerned about? How do we best help them determine what are the next steps? And then hooking them up with ideas around interventions. And you'll see some of the issues with community-based interventions for families, and depending on where they live, what they have access to, as well as like medication management and how they're going to track overall progress with follow-up in DDBP. When you're sharing information with a family about the results, it's really important to keep in mind a parent's emotional readiness to process this information. And this is very individual to the setting. Sometimes it's best to start out with an open-ended question. What questions do you have for me? What concerns do you have for me? And mom might come straight out and say, I'm concerned Johnny has autism. That expresses a different level of readiness than, I'm not sure why we hear the teachers are complaining that, he can't pay attention and has behavior problems at school, but we think he's just fine. Parents value professional comments that express a strength-based approach. And so these are the things that Johnny does really well, right? So starting from that, and think about it, in order to improve in an area that you're weak, you have to lean on those strengths, right? And those are the foundations that you're going to build on for the next step. The other thing is, I feel like parents really appreciate when we remind them that we're here to be team players with them, right? And that we may not have all the answers today, but we're going to be on this journey with them together. Some parents need to hear words that reinforce their ability to parent competently. And it's very common. I'm in cerebral palsy clinic like 3 times a month. And, families will come in sometimes. And I heard a family tell me one time that they know CP clinic is important for their child with cerebral palsy. They dread coming in because they know they're going to leave with 5 more things they need to take care of. And they thought things were going well, but they're leaving with a number of things that are problematic. And it just is emotionally draining. And it feels like a kick in the pants, really. And honestly, parents in those appointments, I find myself saying, you're doing a phenomenal job. Even though that kid is getting tight, you were doing everything we were asking of you with night bracing and this and that. And you need to hear this. It is not for the lack of what you are doing for this kiddo that we're in this situation. It's part of the condition, right? And the look on their faces is just, and sometimes I don't even realize I've done it until it's come out of my mouth. But as a parent, I can tell you that's super helpful to know that you're doing it right, or you're doing it well, or people appreciate how you're approaching the kiddo. And so building on those strengths. And then written materials are appreciated. So whenever we finish up at the end of that information sharing session, they will have plenty of paperwork to take home with them. Do you want to do the social determinants of health?
Okay, so
Any questions to this point?
talking.
I know, right? We might have.
Comfortable.
Nope, you're good. Awesome.
So as you probably have learned, Len's trying to embed multiple thoughts throughout different courses together. So we are looking at the life force theory, social determinants of health. Social determinants of health are kind of where us social workers kind of live. So we often will be bringing up some of these thoughts, concerns. Like Sally said, I read your discipline reports every day. I read down to the section that says plan, and that's where I start when I'm talking to families. And sometimes I have families who are on the other end of the phone with me also looking at the plan section. And then we break it down. Because when they're getting this, oftentimes in DDBP, they get the report from speech, from psychology, likely OT, and the doc. Now, there's one report that synthesizes it all in, but they can see those individual reports. So we're starting with, where can we start? So if we take one action step, what does that look like today? I have other families say, this piece of paper told me to call you, so I called you, and today they left an hour ago, and they have started making every single phone call on all of the papers. But we talk, and that's just parents in different places. And so we talk about, why is that? In my office, we talk about like, why is that? Where are we? And so sometimes it's those preconceived notions about a diagnosis, or a family who came in saying, we've been telling everyone he has autism. We just need you to confirm it so we can do the next step. I need it on a piece of paper with an ND signature behind it so that I can access X. I'm like, great. Our process takes a while, but we will get you there. So there's different pieces. Some social determinants of health can also be like your location, like Sally was saying, we are the negative Nancy's in the room saying that is a great idea that doesn't exist where they live. Maddie, listen to my phone call today. That doesn't exist where you live. How far are you willing to drive? Are you willing to drive 2 hours to get to that appointment every day? That's the closest provider to you. So like that, what we say you need may not be accessible to where you are physically located. So we will talk through all of these things with lots of the recommendations made. A lot of me talking about this insurance barrier or this location barrier or this lack of service providers. So that's me a lot. Okay, we all ask a lot of questions, and it can be overwhelming. So some families aren't going to be prepared for it. One of your families will be more prepared than another one of your families for that this semester. But that can be overwhelming. It can be frustrating. We ask a lot of the same questions over and over. So we would encourage people to say, I know people are asking a lot of the same questions. I need to ask it again because today you're in your OT evaluation and I'm looking at these pieces of your child's life. Next week, you're in your speech evaluation. That person may ask you a lot of the same questions, but we're looking at it from a different lens next week. So we appreciate that we keep asking you the same things over and over. So it can be frustrating, it can be overwhelming, and it can produce some anxiety and some parents being like, sometimes it's fun when we get 2 different parents and one answers it one way and then the next time the other parent comes and answers it really different. And that happens. And I could see my husband and I saying some very different things about some of our kids too. So it just kind of depends on what we're asking and where it's coming from. It helps the family to understand like where you're coming from and what it is that you're assessing and what you're looking at. I don't even know if that last one says. Oh, yeah, that's what we're doing, is getting the information together to make sure that family has what they need to help them advocate. Yes, Susan.
We often see that when we say to families, we saw in your last evaluation, you said this. Is that information currently out? You are trying to tell them you have the grace to look through it, that you read this information. Is that accurate? Can I get more about that? Families really appreciate it when you make that effort of recognizing that you did a chart review and not just blankly again, like you didn't have any of that information. So you guys are going to do so much information sharing in this. And so if you need more information about the same subject or if you want it differently, just acknowledging that you understand or it was reflected that this information was done. Can you tell me more about it? Families really seem to respond very positively. They appreciate that you've done a good chart review. And then it doesn't seem like, I just answered that yesterday. I understand in psychology, they said this. Can you tell me about it from this angle? Parents really do appreciate it when you've done your chart review and that you've listened to your peers in these evaluations.
Yeah. And I mean, I have parents who say, does anyone read anyone else's notes?
Yeah.
Yeah. Our hope is that yes, the answer to that is yes, but I cannot always guarantee that. So then we just start with, this is where we are and the information I'm trying to help you gather. Or sometimes for me, it's, I will take it back to the provider to get you those answers you haven't received yet. But that is We have prepared these families, these 4 families this year have been prepared. You're gonna be asked a lot of the same questions over and over. They all know that they're being seen by people in a position of training, different levels of, in areas of their training. So they know that, and that there's always us faculty people supporting the trainees. So they know they're coming into an educational setting. They're prepared. They know they're gonna be asked more questions than even more. So hopefully that means they work with us. But, oh, wow. Okay, we just keep going. So when is parent permission needed? Well, parents sign, this is Children's World, Children's Hospital World. Parents sign an annual consent to treat, signed by not a parent, but a guardian, legal guardian. Children's World, we say, are you, oh, now I'm gonna forget the line. Are you able to consent to treat? You say yes, we say great, sign here. We don't ask anything else. The only time we ask anything else, today, this came up, is a foster care situation. So a foster parent showed up, said yes. Our system clearly says this foster parent doesn't have custody. We know this child's in custody of Children's Services. So I get a phone call upstairs to work some details. But really, we don't ask many more questions in typical situations as long as the person says yes. That could be grandma who said yes. Grandma doesn't actually have the ability to consent to treat. Stepdad, stepmom doesn't have the ability to consent to treat. They are not a legal guardian of the child. If it's routine medical care, we pretty much take it at face value. You knew about this appointment and you have the child here. Someone told you to come. Hopefully you have the right relationship that we can gather the history that we need for today's appointment. Usually we get an appointment and figure out who you are. So it's stepdad, it's stepmom, it's bio dad who we just haven't met yet. It's bio mom who hasn't come to appointment, or it's grandma who's now the kids living at grandma's, but the parents don't have custody. We find out all those kinds of details and we work with it. If the child were to need surgery or something else, which none of you are performing, there are additional steps. So there are some additional steps when it comes to like an invasive procedure. Traditional outpatient procedures, you say you can consent to treat, great. We know who's coming with these kids. So these patients, we know who's gonna be here, and we will know ahead of time. We've been asked before, like, I'm really in a pinch, can grandma bring him to this appointment? And as long as grandma can answer the questions and get the history that we need, we will work with the family to the best of our ability. But likely we will be seeing parents this time. Oh, really, this might be about releases. Yes, this whole like must be signed. If we want to talk to somebody that's not at Children's, we have to get a release of information form. To do that, typically that is something that Brandy or Maddie will do, and then Brandy or Maddie will probably be the entity reaching out to that outside program. A lot of times we do this to get IEPs, so that we can get a copy of the IEP and or ETR, talk about all those things later, and get them into the medical record. Any questions about consenting to treat or releases? Okay. Suma, who wants to introduce your case?
Age, he reported family reported white race, and he's in Kenton County Schools, and he's at River Ridge Elementary. So that's his school. And then I gathered some information about like how he presented to the pediatrician. So he initially presented in May 2021, and the visit was like he's having a lot of emotional outbursts, and they start like 5 months prior to that. So his symptoms started basically in January 2021. He was repeating at that point. At that point, he was repeating 2nd grade, and he was doing well at school. The symptoms were moderate, and he was reported to be in counseling. But that seemed to think that was not helping very much with his aggression. And then Dad thought that his aggression was somewhat improved at some point, but he was like more tearful, emotional, and that was like May 2021. Then in June 2021, he also consulted the pediatrician because he was chewing on things. So that said that his chewing behaviors were like out of control. He was noted to chew on things when he was younger, but like one particular stuffed animal that he had, but now he was chewing on many things. So pillows, he was chewing on fabrics, on his clothes. So that was concerned about that. Then, and then he has a couple of, he has seen a couple of specialists also. So he has a history of constipation, and he was referred to gastroenterology here. And they saw him, the last time they saw him was March this year. And there was concern of constipation, and he was diagnosed with functional constipation, which basically means is constipation that is not caused by any neurological problems or any other, no thyroid disease, no celiac panel. So they have to rule out everything else, like any organic causes, to call it functional constipation. And they decided to keep him on laxatives and bowel regimen. So that's GI. In terms of allergy, he was seen in February 2022, and he consulted for allergic rhinitis, and they recommended symptom management. He was managed with Flonase and Zyrtec, and he was referred for penicillin allergy testing because there was a concern for amoxicillin allergy. And then the other specialty that he has seen here is urology. So he has a history of like incontinence, and then they found out that he had like meatal stenosis, which means that the urethra, which is where your urine comes out, was like a little bit obstructed. So he was having infection, urinary tract infections. So they did a surgery to repair, and that surgery is called myetoplasty. And after that, he was fine. He didn't have any more UTIs. And the last time they saw him was May 2021. So that's basically all the information that I could gather from him. I couldn't gather anything about IEPs or anything else, or family history. Any questions about terms or things like that?
You might have said this, I missed it. Did you see with his biological parent?
Well, it said that, but I don't know. Yeah.
Do you guys mind repeating the question just so the folks, on Zoom can hear? No, that's okay. She asked you the-
Oh, okay. So what she was asking, what Katie was asking is if we know if the biological parents are in charge of the kid, but I don't have that information. Any other questions?
Did you know any like family history information?
No, I
Okay.
couldn't find any. It's care everywhere, so I have to go like page by page. So it was like hard to find.
Can I ask 2 questions?
Yeah, sure.
One, do you know if there are any siblings? And 2, you mentioned aggression. Do you know if this is toward family, peers, and anything about level of severity?
So they don't say anything about that. And actually, give me a second. He has a sister, and he's usually like aggressive towards the sister. Like they get on his nerve and they can argue for a long time. So that's what it says in one of those visits with the PCP, that he gets aggressive with the sister. But he has a sister. Any other questions?
I think I might have misheard you, but you mentioned irritability,
emotional outbreaks, angry, agitated. Did you say something about his like just general development?
Well, it's a developmental delay. And we usually don't call it developmental delay in kids that are older because by that time we say, oh, this kid has an intellectual disability or a learning difficulty. But this is what the referral said, developmental delay. So probably when he was younger, he was diagnosed with developmental delays and they haven't like updated that diagnosis.
Okay.
That's my guess.
Is there any like birth history?
No, I couldn't find any birth history.
Just one curious, does he also show aggression? Did you mention that, like, I might have missed. Does he show aggression?
Yes, he's showing aggression.
Confidence or self-aggression?
No, to other people. They don't report self-aggression, which I'll ask when I see them. Any other questions?
These are all really great questions.
Thank you. Sorry,
So
there wasn't.
that was fantastic. You know, I-
19 deletion, global developmental delay, hearing loss, and hypertonicity. And the reason why he was referred to DDBP is what they wrote was like a behavioral problems and controlling like his behaviors. So a little bit of background, he was diagnosed with this chromosome 19 deletion when he was 2 years old. He did live in Alabama at the time of diagnosis, but he's been living in Dayton since 2015. And he's seen many specialists through Dayton Children's. The most updated information was from May, I believe, of 2021. And several of the notes are from like 2017. So some of this information may not be super up to date, but I will present what I had access to. And he was involved with early intervention at 18 months. He was seen in March of 2018 at Dayton Children's and had a psychology evaluation and was diagnosed with autism as well. Demographics, he's white, non-Hispanic, lives in Dayton. Other medical conditions, he has amblyopia, so a disorder of his right eye, and he wears corrective lenses. Some mild hearing loss of his right ear, short stature, so he is shorter than the average male of his age. He also has a history of hypoxic ischemic encephalopathy. And to put it in plain terms, when he was younger, parts of his brain did not get enough oxygen that may have affected his development. He is on a few medications. He's on Risperdal, which is a medication, an antipsychotic medication, which can control aggressive behavior, melatonin used for sleep, and then some allergy and asthma medications. He's had his adenoids taken out and ear tubes in the past. Birth history, he was born full term, 40 weeks, vaginal delivery. He did have kind of some instability when he was first born, and he was admitted to the NICU for 10 days, or the neonatal intensive care unit. Going more specifically as far as his genetics, he has this chromosome 19p13 deletion, which includes this PRKACA gene. And honestly, like when I was reading more about this gene, like it just was very like molecular. So I'm gonna let my genetics friends like read more about this. But from kind of the basics of what I had read, you can see some abnormalities in tone, facial features, and developmental delay. From a psychology perspective, like I had said, he had a diagnosis of global developmental delay that probably needs to be updated since his last evaluation. And he had autism testing back in 2018. I did not see any sort of like IEP or ETR. And I wasn't able to see like the full evaluation either from psychology. From a behavior perspective, he's anxious, has frequent meltdowns, very aggressive, despite being on that medication that I had mentioned, Risperdal. From a speech perspective, he has significant speech difficulties. He does use a communication device as well. I was not able to see like his ADOS that he had in 2018. Physical concerns, he learned how to walk when he was 2.5 years. He did see neurology back in May of 2021, and he had hypertonicity or increased tone in all of his muscles. And they did also notice that his calves were enlarged and actually recommended for him to go to a center that had more availabilities of like muscular dystrophy or abnormalities of the muscles. But he did have good reflexes and they did some initial blood work that was normal. From an OT perspective, he does have sensory seeking behaviors of rubbing his forehead against the wall. I don't know his like baseline fine motor or self-care skills. Audiology, he had a normal newborn hearing screen. He had a sedated ABR or hearing test that was done in 2017 that showed some mild hearing loss up to 4,000 hertz. And then in May 2021, they did another hearing evaluation, but he was like moving a lot. That was like what I had seen in the report. And they didn't have like a full like report available because of that. Socially, he has Anthem Blue non-traditional insurance. He lives in Dayton. What I had seen is he lives with his parents and a younger brother, but I'm not sure if that's like updated because I think that was back in 2017 was that note. That's kind of it. Any questions?
Can I have a copy of that?
Yeah, it was a lot.
So sometimes we have a lot of information. Any unsafe or climbing behaviors?
You said any unsafe or climbing behaviors? I'm not sure. I'm not sure also kind of like baseline like mobility. I just know he has like increased tone. So like if he's able to climb, like I'm not sure. Okay. Yes, Elizabeth.
Any more details, like in terms of behavioral problems, is the main concern the aggression? And if we know any more about the aggression, or like what are the behavior problems there?
Yeah, so Elizabeth asked about more of specifics as far as the behavior concerns. And what the referral says was aggressive behavior. That was really it. And honestly, the handwriting of the referral was hard to read too. So I that's kind of all I have for you. Nellie.
So he got his genetic testing in Alabama.
I believe so. Yeah, I believe that's where it was originally done.
Do you have access to the actual report?
No, and it's not an Epic, no.
All we have is what's in Epic. I just emailed Carrie's MRN again, but that's all we have. What is an Epic? And this genetic condition that is referenced starting at 18 months, and that's when it's in Alabama.
Yeah. Griffin?
Yeah, just to clarify, did you say with the ABR, that was a mild hearing loss up to 4
Yes. That, unless that's wrong. That's what I read in the report, like,
Okay.
unless like from your perspective.
No, I
Okay.
could be right.
Okay.
And then when were his scoops placed?
Those were placed in March of 2016.
March of 20.
Yes.
Can you repeat what you said about the dystrophy?
Yeah, okay. And sorry, I'm doing bad about repeating the questions. So question about the like more about the dystrophy. So he had seen his neurologist who evaluated him in May of 2021. He felt like he had hypertonicity of all of his like upper and lower extremities and enlarged calf muscles. They had done initial workup for muscular dystrophy. So they did a CPK test, like, so that looks at the creatinine kinase in their muscles. And that was normal. And his reflexes were normal too. But he felt like the neurologist did write in his note that he didn't feel like he was like a super expert and may need further evaluation at like a bigger center.
Okay, so I talked to this mom, who was a nurse anesthetist, so mom's in the medical field herself. And she said, we wanted to come to Children's because he's a mystery and we don't really get answers anywhere we go. And so we would like to come to Children's because we think we'll get answers from you. So, just her high expectations. Putting that out there, she has high expectations. And remember how I said at the beginning, there's this whole triage process of referrals. Her pediatrician was told he doesn't live in our primary service area. We won't serve him. So her pediatrician was denied the referral. But because we're Lend and we can break rules, I then called her and said, would you be willing to come for a whole lot of appointments? And she said, yes. So sometimes we'll see mom, sometimes we'll see dad. There is a possibility we could see another family member, but they are trying to work it out amongst their work schedules that it's always mom or dad. And I encourage with the information sharing session that it be mom and dad, if at all possible, even if that means somebody has to be on Zoom, so that they both hear the results. Mom and dad are in the home. So she's got some high expectations that we're going to be able to answer some questions that she does not feel she's been able to get answered yet. I said we would try. No promises, but we will try, and I'm sure we will give her some additional information at least. She feels tapped out on what services are available in D. These are your teams. There might have been one edit from last week or last time I came, but this is all updated.
So your experience in ITT is going to be both your experience with the child and the family and interacting with them and presenting that to your peers and having them ask questions and dig a little deeper and having us as a group try to connect the dots between things that we've heard from the family or findings that we had to come up with a diagnosis and recommendations for this family. This experience, when we're all together in the room, team 1 and team 2, and then at the end of the semester for the case conference, you're going to get feedback about that experience. Okay. There are 2 feedback forms loaded to Canvas. One says non-clinical feedback form. So that would apply to social work and the family advocates. And then there are clinical feedback forms. I implore you to read through them based on your discipline to see the kind of feedback you're going to get. There's a rubric, and I want you to know this is not a grade. Nobody's going to get a grade from this class, but there is a rubric 1 to 3 as to whether or not you're meeting expectations or exceeding expectations, or maybe have some room for improvement, and there'll be feedback given as well. So both your clinical supervisors and myself will be sort of taking note of how you are performing as part of a team. So a big piece of this is how you develop your team member skills in a healthcare setting. So that is what these feedback forms are. And you will get one at the end of the first semester and at the end of the second semester. I send them to your children's email addresses. So it's really important that you're checking there for them. Anybody have questions about the feedback? Okay. This is just a scoring rubric. Yes, Jen, Elizabeth.
I was just gonna say for a couple of the family trainees are still working on their badging process.
Yes.
So I just want to make sure I can give them the non-clinical form, but just an FYI that not everybody has access to children's.
Yes. Yeah. By the end of the semester, they should though, right? if anyone does not have access, but we typically, everyone does by the end of the semester. Jen, do you anticipate anybody not having access?
I think we'll be okay.
We'll talk about it in faculty meetings too, and if that comes up. This should be used as, the feedback should be used to reflect upon and to grow from in terms of how this form is used. And like I said, the blank forms are found on Canvas. Sometimes there'll be a category. So at the very last page are things around people who are meeting leaders and, you know, part of that leadership team. And so if you're not a part of that, you're going to have NAs. There might be something where it just wouldn't be appropriate for your discipline to have like interacted with that. But we really did try to make the forms more user-friendly between the groups of clinicians and non-clinicians on ITT. And this is where I turn it back over to my social work colleague, talk about.
So like, we're doing a big jump, job use, like, big jump here. Any questions about ITT? Because this, now we're gonna go into child abuse and mandated reporting and not ITT stuff. Okay, go ahead.
I'm sorry, I have a question on that. Would it be possible for us to get like a?
Go potty. Go.
Okay.
Bio break. That's right. Strike a child with an object as long as it doesn't leave a long-term mark. So it's hard to get physical abuse opened unless there's a mark on the child. So sometimes concerns come up during particularly medical visits, and then you call us and we say, can you please do a full exam and get this child as naked as you can? See if there's a mark. If there's a mark, there's a very different response. There's not a mark. There is really no response. Sexual abuse, rape, touching, fondling, anything in the child pornography realm goes to Children's Services, but likely also goes to a personal crimes division of police investigation. Also complicated, call your social worker. Neglect is omission or failure to provide a basic need. There is also then educational neglect, which you're not sending your kid to school, and kids have to go to school who live here, you have to go to school. You have to be enrolled in school. You don't have to attend. If you don't attend, then you get truancy charges. It's different. The child has to be enrolled in school in some format, and if family wants to homeschool, you're welcome to do that, but you have to do certain things in order to be homeschooling. And then dependency is putting the child in danger of abuse or neglect. So dependency is a form of neglect where basically you're not able to protect the child. Domestic violence or intimate partner violence often follows in dependency. No, maybe child's not being hurt, but we're also failing to keep the child protected from an abusive situation. Witnessing domestic violence is child abuse. So it has to be reported. Any questions about child abuse? Or the forms of child abuse? That doesn't work. Sally.
Yeah.
How do I move it?
Sorry. Go put the cursor, whoops.
That works though. Okay. So mandated reporting. If you're a clinical provider, you're probably a mandated reporter. This is probably not new to you. So if a child discloses abuse, neglect, if you see cigarette burns on a child's arm, you have to do something about it. Required by law. If you don't report child abuse, you can get in trouble with your license and those kinds of things. Anyone can report concerns. As long the recording in Hamilton County that I called today changed recently, as long as it's in good faith. So there are issues where people will, make reports against parents, make reports against each other when we're in a custody battle, that kind of thing. So they try to say, as long as your concern is reported in good faith, it's fine. It is not our job nor my job to prove that abuse is going on. It is our job to report that there is a concern of abuse happening. It is Children's Services' job to investigate the validity of that concern, which involves interviews, home visits, and usually like school visits and things. These are all the people who are supposed to, who are mandated reports. In Ohio, each county has a reporting system. In Ohio, we're county-based, and we also call this Job and Family Services, or JFS. Sometimes we will globally say Child Protective Services, or CPS, because in Kentucky, it's the Cabinet for Health and Safety Children, Health and something children. Indiana, it's something different. And the reporting systems for all of those states are different. Ohio is the easiest. It's the county where the event happened. And so call us if you don't know who to call. You call a social worker who tells you who to call based off of the information you have. It's all right if you don't have all the information, you report what we have. We tell you who to call. Make sure you have the number. Big counties in Ohio, like Hamilton County, that number is staffed 24 hours a day, 7 days, 365. That number is staffed at all times. Smaller counties at night, you're calling the sheriff's department. But it tells you who you're calling, so you know that. Any questions about reporting? You might have more information on reporting, but general. It's really everyone's favorite topic. So Hamilton County, it's 2 for 1 kids. Yes.
Do we have to like fill out a form?
If a report's made, I'll get there in a minute.
Like if we need to report something? Because like in New York, we have to fill out a form.
So there is in Epic, when I make, you don't have to fill it out, but I have to fill out a different encounter type. There's a special encounter type for child abuse with a smart, I don't know, smart phrase, I guess it's a dot something, then I have to, and I pick the right one. And then I have to go through a bunch of information, ask a bunch of questions. I answer to the best of my ability. Technically, that does get sent on. If an MD was involved, we send that to you guys to fill out your second piece. Usually that piece doesn't actually happen, and it's okay. Because that would be, you saw a mark. Typically, we're not seeing a mark and ending things there. We'll see a mark, we'll send them to the ED to get photo documentation of the mark. So then there's an ED document. So we fill out paperwork, we make the report. Our paperwork is then each night downloaded and faxed to the correct county to go along with the report we made by phone earlier in the day, so that the county gets 2 copies of our report. So you don't have to fill out any specific information unless Abby, Megan, or I say, hey, can you fill out this mark? But we will let you know that. So in Hamilton County, it's 2 for 1 kids. Every county has a different number. That's why it's complicated. So call someone if you're not sure who to call. So the person who answers the phone varies, and their willingness to work with you varies. So, but basic information, they need to know the child's name, date of birth, who they live with, address, phone number, and what your concern is. It's really awesome. They're gonna say, so you're gonna say dad's name is David Green. Okay, what's his date of birth? I have no idea. It's okay, I don't know. I don't know. If you don't know anything, I don't know, it's a fine response. They obviously want to know, like, what's your concern? Who is the suspected victim and who is the suspected perpetrator of whatever has happened? So if it's a child with a mark, he says, Daddy did it. Okay, what's Dad's name? Helps them. It also helps in situations where, does he live with Dad? So does Dad have access to this child? Also depends on when they make their visit. So if the person who hurt the child, so it was Uncle Joe hurt me, but Uncle Joe lives in Alabama and we just went and visited him last week and now I'm not gonna see him for 6 months, we're not so worried. We may or may not report it. So, you know, that depends on what their response will look like. So what happens next? JFS staffs it, which means they talk to their supervisor. It gets documented. Anytime you call a hotline number, it is documented in a system. So sometimes we say, I'm calling this in, I know it's not going to get investigated, it's not going to get open, but we're building a case so that when people keep calling it in, it keeps getting documented. You keep seeing, look at, this isn't the first social worker at Children's who's had this concern before. This other person called it in, this dog called it in. Starts to build a case. Most of the time, it gets staffed and closed. And you get a letter about 4 weeks later telling you that they didn't do anything. Sometimes you don't get your letter at all, but they're supposed to send us a letter if they close it or if they investigate it with the investigator's name. By the time you get the letter, it's out of investigation, because investigations really only last about 30 days. And then they have to decide at the end of the 30 days, do we keep this open and ongoing? Are we going to court at some point in this time? Children's services also, social workers sometimes get a bad rap. We are not baby takers away. A court has to make that determination. Social workers or children's services workers are the people who go out and remove the child. But courts make that decision. Only the judge makes that decision, the social worker. So the case can be moved to temporary custody of the county. It could be closed. It could go into investigation. And then after investigation, it could go into ongoing, or it can be closed after the investigation. Most of the time, then they do the investigation. They say, we see that there were concerns. We've addressed those concerns with the family, closing this case. So for medical neglect, they weren't going to appointments. I told them to go to their appointments. They've gone to their appointments. We're closing out of investigations. And cases can be referred to other agencies like juvenile court or criminal court, depending on what happened. I mean, if it's sex abuse, child pornography, pretty extensive physical abuse, those will go on to criminal court. Any questions? So you're, at least on Tuesdays and Thursdays, you're in a hospital. I know other days of the week, your placements might have you in a school or might have you in a community agency. You may not always be here. So your support for children's services reporting and child abuse concerns could vary depending on where you're at. It can also vary because you're sitting out at Mason Children's, where they're not in a social worker there, versus sitting here, or really sitting at base where there's a lot of social workers there. So even within children's, your support can feel different. So we want, like, if you have concerns happening in your community agencies, or when you're not at children's, or if you're thinking about jobs next, and you want to talk about these kinds of questions, bring them up this year. If you're at children's, consult social work. The answer is consult social work. Consult social work early, consult social work before the patient leaves. If you're at a satellite, there is a pager number. There's a social worker on call 24 hours a day, 7 days a week, 365 days a year. In-house, there's always a social worker. So if you're at a satellite and it's 6 o'clock at night, you page that, someone will return your call. So when you're at a satellite, you'll get a call back. You'll make a page, someone will call you back. If you're in DDP, it's maybe Matt or Brandy, or there are 3 of me. One of us will be there. We will support you. We will help you figure out your next step. And if the child made a disclosure to you and won't make a disclosure to me, or made a disclosure to you, then left, we would need you to be on the phone call to disclose firsthand what was disclosed to you, but we will walk you through that and make sure you are comfortable. And when you don't know things, we say, just say, I don't know, it's okay. But when you're here at the hospital, there's a whole lot of support for this. Not everywhere you go though. So this is where there's specific documentation in Epic. So there's my chart. Everything gets released immediately to the family. Child abuse reporting forms are something we always can hide from the family. So we can check the little button over, because if we're so concerned that we're calling children's services, we're probably concerned about the child safety. Any questions about reporting? Oh, okay. And then the Mayerson Center. Has anyone heard of the Mayerson Center? Okay. So the Mayerson Center, Safe and Healthy Children. Their main they do is provide education and training for the prevention of abuse and neglect. They're really working on community prevention. Lots of trainings, lots of work going on in schools and communities to prevent abuse and neglect. They also have, so sometimes I call over there and I say, I got a kid and he's got a lot of boundary issues. We're touching a lot of people. They have coloring books at all kinds of different developmental stages about good touch, bad touch, safety, those kinds of things. So they've got lots of resources that we can give directly to. They conduct medical assessments and forensic interviews that are referred to them most commonly by children's services or the police. So to go to Mayerson and have an interview, we have to have a victim and we have to have a suspected perpetrator of a abuse, possible crime. Those are really hard interviews. It is always a social worker, depending on what happened. If there's photo documentation, if there's been sexual penetration, within 72 hours, there might also be a medical visit that goes along with some data collection. And then they do have access for counseling for victims. And they're beefing up some of their other resources and support services that they're offering as well. So if you have a concern for abuse and neglect and it happens while you're sitting in Len, do not call Mayerson, call DWP social work. We're the front line to that. It doesn't go to Mayerson unless there's already a criminal investigation and the police have already turned it over to them. Any questions about Mayerson? They do like a lot of things though, but that's about any of today. ITT. Super exciting values at the end of the day.
It's early.
Yeah. We talked really fast.
It will start to make sense.
Yeah.
This is like ITT is like the course that has the most moving parts and is the hardest to wrap your brain around. But it'll make sense, we promise.
And it's so fun.
Yeah. It is.
I've been a clinician for 30 years and I still keep learning from the folks that Lynn. Awesome. And ITT, yeah.
You have a question?
Yes, so I'm on team 1. We start next week, not.
Audiology, genetic counseling, Pete's fellow and social work.
That is recorded, right? So you can watch it
Yes,
after. If
So-
we're not- If we can't watch it when it's after.
correct. So all of the ITT meetings are recorded on Zoom. And then at the top of your modules, I don't know how you navigate Canvas. I navigate through modules. At the top of the modules, it says team 1, team 2. The recordings will get dumped up there. It will take a couple of days, maybe a week, for the recordings to appear there. But they will get there. So yes, you can always watch them following. Audiology never works because the booth is a bomb show. Yes. So we tried so many things, but we cannot get audiology.
Watch audiology. Come on in.
Mhm. It,
Bring me a snack though, please.
we tried a lot of them. And like the Wi-Fi just dies as soon as you shut the door. You shut the door, the Wi-Fi.
And our students lose their mind because they've taken a lot of time and effort to try and set up yet another piece of electronic equipment for our patients. So if you would like to watch audiology, we love to have visitors.
And there's always.
I'm confused, wait a second, just a minute. I'm confused by that because I did the FCC evaluations last year. And I was able to watch audiology and I saw some great
Did you see the
evaluations,
entire thing?
yes. So
Well,
I'm-
Samantha told me that it stopped, so I stopped.
There was maybe a little portion, but no, she was fabulous. I met with
She
her.
is fabulous.
We can try. So audiology is the one. Audiology is the most difficult one to record because of the setup of their soundproof booth.
I would say OTPT is a little challenging.
Because the
kids
room-
don't stay still,
The kids moving and the room is huge.
however, we do our best.
Right.
Everybody does their best in the land of hope.
That's right.
I will say for evaluators, don't be surprised when the person you're evaluating goes up to the laptop is used to record them or whatever, because they are intrigued with that. And so that's all right. They'll come up and look, but usually it's fine.
So wait, I have a question. So for the appointment that they have with us, it's, I think, they and me, 9 a.m. on the 20th. So what is the recording? It's like a computer?
Yes, so one of the evaluating trainee, somebody in the morning needs to go up to the Lend Lounge and grab a computer and a microphone. We have Anchor microphones. The microphones on the computers are awful. So Lend bought some microphones, that Bluetooth microphones that sit out, that actually you can at least hear now. And OTPT, we could hear. You couldn't see everything, but we could hear it, which was helpful. Jen we might have one in the bag. So we'll make sure those are all charged up, ready to go. There is a sticky note that says this is how you log on to the computer. There's a sticky note that says this is how you power up this microphone.
That's only for recording, not to take the notes.
No, don't take notes on that. Please don't. Because then we hear the click, click. But yes, so there will be a laptop just for recording.
Okay, so the laptop, my laptop, and I guess.
So you're not in a medical room. If you go to the ITT schedule, we're in the group treatment room on the treatment side, so that you're in a big space. Which has an observation deck to it as well. So social work, they might both actually be sitting there observing. And then when there's like a break, might go in and talk to the family. And we should bring extra tools that. So there's an otoscope on wheels that is never charged. It's never charged. And that's all you bring in, right? Is the otoscope on wheels?
Yeah, we have a little kit.
Yeah. Yep.
We'll take in everything else we need.
And then things are dead and we're going and grabbing other stuff. So, because we don't use it enough, but yes. So pay attention to the room number on the schedule because it may not be where you typically evaluate. And it may change the morning of, and your clinical supervisor would tell you that, where to be.
Will it be like, I know it's just in a different room, will it still have access to like toys, little widget things for the child?
That particular space is usually disorganized. So I don't know if you have, I don't know if there's toys in a closet that you can unlock. There's a lot of closets that you can unlock in that room.
But it's in the psychology side,
Yeah.
It's not in the.
Correct.
I don't know.
I don't know either.
There is a.
Yeah, you can get access
Yeah.
to all of the stuff.
Yeah.
On the third.
You can bring a
floor.
distraction box.
Yeah.
Right. We're gonna be.
And we have toy closets on this side. Yes, you sure do. It's very lovely toy closets. And then there's you could grab a distraction kit out of one of the medical rooms.
I think I remember it was about the recordings. We only have to observe like 2 of those or something like that, not all of them for our team.
Right, correct. You can, whatever you can observe that helps you with your evaluation, you're welcome to do that. We're also going to talk about all of it in ICT. But for your observations across discipline, you're going to watch somebody else evaluate your patient, and then you're going to watch an evaluation on the other. Right? Okay. But that's for it's multiple observations across discipline. Any other questions, concerns? It will make sense. We promise. If you have any questions about where to be, you can always ask. I like memorize their schedules. So you can ask me where you're supposed to be, depending on your team. But email Sally, myself, and obviously your clinical supervisors know because they're supposed to be there too. So just reach out if you've got questions. Okay. Thanks, guys. Okay. Thanks, Susan.
And I